Hello, everyone. This is Eric Glazer, and welcome back to our live recording of the Bright Spots in Healthcare podcast produced by Shared Purpose Connect. We bring leaders together to not only inform you, but also unearth bright spots, successes at health plans, hospitals, and other healthcare-related organizations around the country. Our goal is to identify as many bright spots as possible so that you can determine if the ideas shared during this episode can be applied at your organization. We believe this approach of finding a bright spot and cloning it is the most effective strategy to improving healthcare in our lifetime. If you have not subscribed to the podcast, I encourage you to do so. Just go on to whatever podcast app you use and type in Bright Spots in Healthcare. You will then have any episode that we drop in here with all the great expertise from all the guests that we have on the show landed right on to your tablet or your mobile phone. And if you do enjoy the show, I encourage you to also rate it as well. That helps more people in our business find the show and benefit from the same bright spots that you benefit from, so that we can continue to circulate those and hopefully make healthcare better for everyone in this country. Our topic today is boosting health plan performance, improving provider-centric risk adjustment, and staying compliant. I know that's a mouthful, but you all, if you're on the call right now, if you're listening on your podcast feed, you know what an important topic this is. And our production team has assembled an all-star panel for you. As usual, to save time, because we are super, I know I always say this, I always say we're jam-packed. We are really jam-packed today. We're going to save time and allow you to look at people's bios by clicking on the link. If you're watching live on Zoom within the chat, it'll be in the podcast description if you're listening to the show feed. Our partner in crime, our sponsor for today's show, is none other than Vatica Health. Why Vatica Health, you may ask? Well, they just got named best in class for risk adjustment in 2023, and KLAS also named them to its Emerging Solutions Top 20 list for innovative companies that have the greatest potential to impact healthcare. So you are all welcome. I'll tell you more about Vatica Health later on in the show, but if you cannot wait, you could check them out right now at vaticahealth.com. All right, let's get to work. I want to spend the majority of the time, or at least the first 35 minutes or so, talking about strategies and approaches. So I want everyone who's listening to take your pen and pencil out. There's going to be a lot of great notes to take, a lot of interesting programs and bright spots to note here. And I want to start with Frank Shipp. He is the executive director at Johns Hopkins Clinical Alliance, which is part of Johns Hopkins Medicine. So Frank, let's start with, I just want to talk to folks who are at smaller organizations, maybe mid-sized organizations right now, and talk about, one, why is risk adjustment such a heavy lift for providers? And how can health systems who are listening with those limited resources take a step forward in their risk adjustment approach? And I'd love you to talk about maybe like what they should do at a crawl stage and what they could do maybe in a walk stage. Is that okay? Frank, you are on mute, and I may do that today. I do hundreds of these, and I always do that. So,
thank you, Eric. Well, thanks for that. Well, certainly, regardless of size and what stage you're in, especially in the early stages, it is critical that you get provider buy-in and before you move forward to try to develop even some basic workflows. It's been my experience that two keys certainly to establishing trust and really instilling confidence in your providers are, first of all, one is to minimize compliance liability or their perception of it. And obviously, they're concerned getting into this. And one way certainly you can do that is to provide regular feedback from subject matter experts, not only on what they're achieving and their results, but more importantly, on the appropriateness and the accuracy of their documentation. So they feel comfortable from a compliance liability standpoint. And you can do that, of course, with post-chart reviews, and again, using some subject matter experts. But the second really hurdle, and probably even more important, is that you need to develop a workflow using the resources you have to minimize the impact on provider productivity. And looking back in the early stages, what we did, and certainly the first step I would recommend, is to assess the capabilities of your EHR. And what we did certainly was to embed or load information into our EHR. So what we did was we took the information, the suspect conditions list that we received from the payer, and we cross-referenced those with our patients in our EHR, which patients had scheduled visits upcoming during the next 3 to 4 weeks. And that payer data was always very helpful, would list the attributed physician, the patient, and the diagnoses or the suspect conditions to be assessed. And we would load them into the EHR to give our providers a heads up, and we would educate our providers of what was coming. Now, another way to complement that workflow was to do some pre-chart reviews. And to do that, obviously, we use coders. Now, not all organizations have coders that are knowledgeable in risk adjustment, but that's certainly a strategy that we deployed to help build that competence in the coders that we had. They would go in, do pre-chart reviews, and really set the table, if you will, using that information in the EHR. So when the patients were being roomed in, the providers could really see what was in front of them in their problems list or what have you. And then, of course, so the advantages of using those two workflows was, one is you're using your internal resources. You're building your own internal competence, if you will, for the long run. And you're also helping to build trust, because your providers now realize that they're relying on your own internal coders to help them to justify their documentation. On the downside, of course, those workflows or using coders can be expensive, and to build that over time. There are opportunities or companies that provide coders, external coders with that expertise as well, but again, that can be expensive. So I will say this, I think it's really important to use what you have, use the technology that's available to you through your EHR, through your internal coders. Consider developing more skills within your internal resources, and then over time build and look forward to more advanced solutions. But going back to the buy-in with physicians, really critical to establish that and engagement. And I'll end with this. As you develop even basic workflows, you will find a handful of physicians that are very interested in this, and you want to target those to be your physician champions. If you do have limited resources, start off small, pick a practice, pilot it with a small group of physicians, and those will ultimately become your physician champions as you deploy more advanced tools and more opportunities to improve.
Frank, quickly, the EHR that you guys use at Hopkins?
Well, we use Epic at Hopkins, certainly, and listen, that helps a great deal. But the years I was referring to in the early stages of a CIN were in the Northeast, and we used Athena Clinical at that time. And even Athena Clinical was allowed us to embed and load these suspect conditions into upcoming visits in the chart.
So I think you did a great job summarizing that. I just want to make sure everyone caught that. So you almost have this two-pronged strategy. The first would be that I would probably, my words, not yours, of course, this old school approach of, hey, if you don't have you could make improvements just by assessing your capabilities, just by assessing the relationship you have with your healthcare managers and your care teams and those providers, and then being able to, if you have the ability to kind of move a step forward with some resources, just training in-house coders. Those two kind of strategic approaches alone can improve. You also mentioned at the very onset that really you need to take an empathetic view at the physician. And we're going to talk a lot about the provider throughout the flow of today's conversation. And you mentioned that the first thing that they're concerned about is liability, or at least a perception of that liability. So that's really important. And then also the productivity and the workflow. So, and you're going to hear that, folks listening, an underlying theme there on productivity and workflow. I know there's been a noticeable uptick of claims against Medicare Advantage organizations, both on the provider and payer side, and what government states are sort of aggressive initiatives focused on boosting risk scores and associated payments in preparation for this session. I was reading a white paper that Vatica Health had written. It's a 4-page detailed white paper on mitigating compliance risk. And I think, Frank, you brought it up, so I'm going to bring it up to the group right now. I think folks listening should look at this document, peruse it, circulate it amongst your teams. If you want me to send you a copy after the show, I'm happy to. I'm going to put up, I'll have Sherry Keels, our producer, put up a poll. I'll email it to you. If you are listening on the podcast feed, we'll put a link where you could request it as well. Sherry and the team will put up a link. You could fill up a quick form and I'll email you that PDF if you're listening to this on your walk, run, or drive. All right, I want to bring in now Greg Kimmer. He's the president and CEO of HVO Health Plans. And I'd love to talk about your strategy, Greg, and how would you describe your risk adjustment strategy and how do you approach risk adjustment differently or think about it at least, Greg?
Yeah, as articulate and as well-informed as Frank's dialogue was, I don't know that I can add much to it, but I can tell you how I could supplement it with the way I approach risk adjustment. And that is, I'm not a clinician, okay? But I've always seen risk adjustment as a clinical function, okay? Not a revenue function, but a clinical function. And I'll quickly explain why. As a payer, we cannot get an accurate description of the acuity level of the people we've signed up unless risk adjustment is done correctly. We can look at the utilization side of things, but unless we know that this portion of membership over here has this number of HCCs that have or have not been revalidated, or AWVs have not been done or have been done, we don't have an accurate picture of what we're dealing with. I think it's important to recognize that in individual Medicare Advantage, it's the only form of insurance in the country that I know of where the word underwriting does not exist. Okay, if you're eligible, we have to accept you. That's a privilege, but it also comes with it a lot of management, oversight, and making sure, again, that we are fully informed of the acuity levels of our population. So I think it's incumbent upon us as partners, and I emphasize the word partner. Partnership is where two parties win. In partnership with providers, creating a framework around them such that before, during, and after the point of care, they are not only able to operate at the top of their license, but they feel comfortable and equipped to document to the highest level of specificity. To me, that is the tagline of risk adjustment. You have to create a framework around the provider community such that they can document to the highest level of specificity, such that you have an accurate depiction of your population. That's kind of how I've always thought about it at HREO. That's what we strive for, creating that framework around our provider partners such that they can succeed with this.
That's great stuff. Document to the highest level, document to the highest level of specificity. Whoa. You're gonna have to help me out with that, Greg.
I have to say it 10 times a day to myself.
You hit me with a term that kind of got my tongue twisted. Not good. That's great. And so I want to, I'll bring in Haas Rafat. He's the CEO of Dr. Haas Rafat, the CEO of Vatica Health. Why, Haas, is it so important to make everything provider-centric when it comes to just in-office risk adjustment?
Thanks, Eric. I just want to make sure you can hear me okay. It was blipping in and out there for a second. Can you hear me?
I can hear you fine.
Sure. So listen, there's been a lot of significant developments, in our space just in the last few months. We had the final RADV rule come out at the end of January that said that CMS can ultimately extrapolate their findings in terms of error rates across the entire population. That makes fines and penalties much more significant. We then had a final rate notice that came out in April where, there's a 3-year phase in of, a different risk adjustment model that's going to ultimately reduce the number of ICD codes for risk adjustment and also kind of changes the value associated with some of the conditions, particularly those that are lower incidence but more intensity. All of this means that you have to make sure you're doing complete and compliant coding to, have the best result as a payer. And, as Frank and Greg have said, ultimately, the best place to get that done is at the place of care, meaning I completely agree with Greg. This is not a revenue exercise. This is a clinical exercise, and there's lots of benefits from doing it correctly, but you also have to make sure you do it efficiently. And, for those of you who've read my background, I've had the opportunity to run health plans as well as, to run Vatica now for almost 10 years. And it's been my consistent observation that in order to achieve all of these things in partnership with a physician, you've got to make sure that you're ultimately fitting it into the workflow and minimizing the amount of provider time and abrasion to do this well. And I think a point that Frank made that people often overlook is that the physicians want to make sure, especially because they read the newspaper and they read about all these lawsuits, that they're not, participating in, something that they, could come back to them and create liability or, claims of fraud and so forth. They don't know much about the process. So at the end of the day, it's critical to get this work done at the place of care for compliance and completeness. But it's also important that the providers are educated about why they need to do this and how we're supporting and protecting them. And that requires technology, data, and people. You've got to have all three to really make that work. But when you do it right, you're ultimately achieving these things that I'm mentioning, and you're engaging providers in a way that's acceptable to them and contributes to the better quality of care and continuity of care. So many reasons: compliant yield, better quality and continuity of care, more engaged and educated physicians that ultimately are going to achieve the CMS, formerly 3-part aim, now 4-point aim. All those things are the reason why it's critical to make sure you have success with what we'll call a PCP-centric or place of care coding and documentation initiatives.
So Haas, if people are on the plan side in the audience want to think about coming out of this episode, how to move forward with a new approach to risk adjustment, what are some of the things they should do and be thinking of to get started?
Yes. So, the first thing I'll tell you is, as a former health plan executive, I can give you a little bit of history here because I've done this for so long. I remember, running a 60,000 member health plan in Tennessee. And we were trying 10 years ago, maybe 15 years ago, to get providers to do this work. And we would get back 1,200 physician assessments, and we would ring the bell like that was a great outcome, right? And like just our expectations were so low. And now, just in the experience we've had at Vatica, there's some markets where, we're getting 80% of the physicians to participate, and we're getting, member assessments on, over 70% of their membership. So I just want to, first of all, share the fact that this can be done, right? And there's a lot of people who are out there that have, run programs like Vatica and, other companies that, represent, great sources of best practices and learnings about how to do this. So I just want to encourage everyone on the health plan side and even on the provider side to make sure you're taking the time to get educated from, the players in the space so that you're getting educated about things you want to do, things you want to avoid, what kind of choices you can make in terms of what you do yourself versus what you rely on partners for. And there's no one right answer. It really comes down to, what your business objectives and culture are at your company and your assessment of your provider network and the providers, to Frank's point, that are ready, that have, physician buy-in, a physician champion, and so forth. So, my message is simple. You want to get educated. You want to be taking steps to move forward. You ultimately want to identify the provider organizations that represent early adopters that you can collaborate with. And you need to make sure that you're flexible because these provider organizations have different needs. And if you just go out there, with one solution and a one size fits all, it's not going to work. It's also not going to work if you go out there and just say, it's just tech, or it's just data, or it's just people. It's really that combination of all of those things that's then implemented within the workflow of that provider organization in a way that is acceptable to them that's critical. The last thing I will say that people often overlook is you've got to make sure that whether there's direct incentive payments or there's the sharing of broader value-based care incentives, that the providers and their staff are compensated appropriately for their time. I think one of the mistakes that I made a long time ago, and I still see people make, is they're not tying compensation directly to this work for the time that people have to put into it. And that's treating providers as well as their staff. At the end of the day, if all that money just flows to the provider organization and doesn't make it down to the front lines, I can tell you, I've seen it over the last 10 years. You ultimately don't get the kind of physician engagement, physician participation, quality of work that the physicians and their staff are really capable of, because they're disgruntled about, not being compensated for this. And if you're asking them to do this work, and it's cutting into, an already busy schedule, they're really going to resist it. So I just want to finally make the point, make sure that you align incentives and compensation with the time and work that you're asking the treating providers and their staff to do, and leverage that staff, including mid-levels, APPs, nurse practitioners, physician assistants, to take as much load as you can off of those providers, so that at the end of the day, it's a reasonable balance of time and money for their work.
Got a lot. Yeah, you mentioned first of all, activity-based pricing of compensation. Probably, I've been looking at that as a topic. I mean, you're now inspiring me to look further into it. Maybe Sherry, we could add that to the survey. Incidentally, you also mentioned, and I just, to our listeners out there, especially those listening and watching live, using organizations outside of your company to educate folks on best practices to improve risk adjustment. We always send out, those of you who attend regularly know, a survey to get your feedback on topics and how we did today. I'm going to include a question in there that if you want to get an introduction to Haas or one of the senior members of his team to get educated, not get sold necessarily, but just have a meeting to get educated, you could request that, and I'll make a personal introduction to someone on the Vatica Health team, and you could just get on the phone and ask questions, and I'll be able to answer them for you. And you could see if there's any insights there that could lead you to if that their solution modifying something you already have in place. I know Michelle, I'm going to bring in Michelle Illich. She's the Vice President of Network Solutions and Value-Based Programming at Priority Health in Michigan. Michelle, we're talking about how hard it is to bring payers and providers together and why it's so hard. How are you guys leveraging technology, maybe like that next stage from, like, let's say what Frank set the stage for us. Frank talked about sort of a old school and medium, like walk and crawl and walk. What's maybe the next level of how you're bringing in a partnership between payers and providers leveraging technology?
So Priority Health is a provider-owned health plan. We're the third largest provider-owned health plan in the nation. And as many of us on this line have probably lived, as with all things technology, it's not the tool. It's how you implement the tool. It's not the tool, it's how you implement the tool. And it's the workflows, and we've all talked about the provider engagement that you can cultivate. The decision for us to invest in Epic Payer Platform and being the first carrier in the state of Michigan to make the decision to bring Epic Payer Platform to our market was an easy one, because we know at the end of the day, electronic medical records are not designed to amplify workflows. And most provider groups have three screens. They have their practice management system, they have their EMR, and then they have their disease registry. And so a huge part of that friction between payer and provider is the annoyance that a payer offers, myself included, asking for those chart requests. And so we wanted to be serious about the fact that we don't exist to ask for charts. We exist to inspire workflows and to wring out the waste in healthcare. And so what we're doing with Epic Payer Platform is really making sure that we're at the cutting edge of the workflow redesign. we asked for that chart, we better really need that chart. And so that's why we gave the data liberation, I like to call it an Epic Payer platform, so that the information's there. And so we, as the carrier, can grab what we need without plaguing that responsibility on a busy primary care practice, trying to get that 45th patient in. And also, as the carrier, making sure that we're not missing a beat with our CMS regulations in terms of providing that data. So it's really all about that third screen view. There may be some of you thinking to yourselves, okay, but in my state, we're not an Epic state. We have, a lot of different EMRs. We're really leveraging Epic Payer platform as that dip in the water to really inspire the larger conversation about workflow redesign for every EMR that we have providers that use.
I want to come back to workflow in a little bit, Michelle, so stay warm there. I now want to bring in Capital District Physicians Health Plan and their Director of Clinical Documentation Integrity and Coding Compliance, Colleen Genatazio. Colleen, could you tell us a little bit about CDPHP's strategy to reducing gaps in care at point of care? By the way, Capital District Physicians Health Plan is in Albany, New York, if you didn't know. Shout out to the 518. But maybe talk about how you guys are focusing reducing gaps in care at point of care, and how does it differ from what we've heard so far?
Sure, Eric, thank you. So we've actually been working for years on breaking down that wall between payer and provider. We started our first iteration of a clinical documentation integrity program about 5 years ago. At CDPHP, we do believe that we have a responsibility as a payer partner. And I love Greg's focus on the definition of partnership, right? We both benefit from this. We believe that we have a responsibility to ensure that the data that we're presenting to our providers is three things: timely, actionable, and trustworthy. Our CDI process brings together people, process, and technology. And our first focus looks at our analytics and our reporting, right? Then we move to our certified coding team, who act as the buffers between that data and the doctor. They review the patient's charts to ensure that any condition that we're asking the provider to review is truly relevant to that patient. If it's not, we're going to use that information to improve our reporting and our analytics. If it is relevant, then we would help with the clinical decision support at the point of care. That information is then shared in the form of a compliant query, which is given to the provider before the visit, which is key. This process gives the provider a curated list of information that they would otherwise not have the time to look at with their limited time with the patient. Then we make the process full circle by reviewing the chart right after the encounter to ensure that all conditions that impacted the care, management, and treatment at the time of that encounter are compliantly supported in the documentation. This process, which we call our full circle CDI, has allowed us to build those better relationships with our community providers. And it has also helped us to identify when EMRs or workflows might be acting as a barrier to showing the great care that our providers provide.
So Full Circle Clinical Documentation Integrity Program, or you call it Full Circle CDI. I have a question how it ties into your bigger strategy, but just a quick follow-up on what you just said. Are there 2 or 3 things that sort of are the core pillars to that program that make it hum if someone was going to try to mimic or modify what you guys are doing at their organization?
Yes, I would say the focus is on continually improving the reporting and the analytics, right? Our data has to be spot on and trustworthy. Too frequently, we're seeing payers send out data that's just an irritant to an already busy provider. The second is a well-trained team of certified coders. And I always put the emphasis on critical thinking for our coders, right? It's not just, this is, for every case, this is how we code diabetes. They really have to look at that patient's record and tell that patient's story. And that's the foundation of our program.
Got it. CQI for reporting analytics and making sure you have a well-trained certified coder program that focuses a lot on the skill set of critical thinking.
Absolutely.
How does this overall approach of Full Circle CDI apply to your overall HEDIS and STAR strategy?
Yeah, so we realized many years ago that we're out there knocking on doors for our HEDIS efforts, and then we're sending yet another team out to talk about risk adjustment. We overlap. We have a really close partnership with our quality team here at CDPHP. So we ensure that we're sending a cohesive message. Our physician educators are actually cross-trained on key HEDIS and STARS metrics so that they can speak to the requirements when educating on chronic conditions. I'll give you an example here. So our chronic conditions education for diabetes, we focus on documentation and coding needed to tell the story of the patient with pre-diabetes versus uncomplicated diabetes versus diabetes that has now impacted various body systems. Once that definitive diagnosis is established, then we outline the next steps from a HEDIS perspective. This would include making sure that the patient has A1C control, an annual eye exam, blood pressure control, and a kidney health evaluation. What this approach does, it allows us to help providers know exactly what is needed for that patient, rather than scheduling 2 separate visits for coding and documentation on 2 separate initiatives.
Got it. That's great. Communication at its core. I want to, with that in mind, take a quick break for a PSA here. I said at the beginning of the show that I thanked our friends at Medica Health for supporting this episode. For those of you who joined late, I wanted to provide a little bit more detail. What a great organization they are. They provide risk adjustment and quality of care solutions for plans and health systems, and they just got named best in class. You know that organization, KLAS, for risk adjustment this year. And they also were named by KLAS as one of the top 20 emerging solutions for innovative companies that have the greatest potential to impact healthcare. So how do they do what they do? Well, they do what they do by pairing clinical teams with cutting edge technology that increases patient engagement and improves coding accuracy and completeness, everything that we're talking about. And simply put, they're superior at identifying and facilitating closures of gaps in care and enhancing communications. We just talked about communications and collaboration between providers and plans. And the company's unique provider-centric solution helps all those parties, especially patients, achieve better outcomes together. And that also includes compliance, which we spoke about earlier. You could check them out at vaticahealth.com. All right, Greg, I'm nervous to bring you back because I can't get tongue-tied again like that. Earlier, you were talking about risk adjustment as a clinical program. What's maybe another core component of your RA strategy that maybe some organizations don't think of as part of their RA approach?
2 words: member retention. And I know that may not always fall under the description or the category of risk adjustment, but here's why member retention means a lot to me. All the things we do inside of a health plan are focused on one thing and one thing only: the member. Okay, at the end of the day, if the member never chooses us, none of this stuff matters, right? Risk adjustment, clinical, none of it matters if they don't enroll with us. So we work hard, we invest, and we create, an environment whereby brokers and our sales leaders can enroll these members. Why not work just as hard to keep them? And the way that affects risk adjustment is obvious. You're always paying claims today for the risk adjusted revenue you hope to get next year because you incurred those claims. But if you don't create a pleasing member experience, if you don't figuratively wrap your arms around members, they may leave. I can't share specifics, but being at Atrio for the past 8 or 9 months compared to prior lives, our voluntary disenrollment rate is very, very low. People generally don't leave us. They will walk into our headquarters and ask questions about their ID card to get an OTC catalog. It's your around the corner friendly health plan, and it's a really cool secret sauce, if you will, Eric. So keeping the member around so that you can enjoy the risk adjusted revenue that you work so hard and pay the claims upon to get in the first place is so key, because if you sign up a member and they leave, 1 minus 1 is 0, right? And so I invest in and spend a lot of time thinking about creative ways to keep members around that we work so hard to get.
So I just want to make sure I'm industry standard for voluntary disenrollment is probably between 5 and 8%. And you're saying through this approach and this focus, you guys have a far less, not small.
Yes, it is. It's you know, and it's such that we, it's not a coincidence, you know, this, if it happened in 1 year because of COVID, I'm going to state, you know, something that's a shocking revelation. COVID affected our world, right? But even outside of COVID, we pay so much attention to keeping members around that we work so hard to sign up that our disenrollment rate is at a very manageable level. And it allows us to not only predict more accurate risk-adjusted revenue in the future, but to frankly have more of it in a compliant way because these folks are sticking around. We go out of our way, and I encourage the team to go out of their way to do everything you can to make that person not even consider another health plan. Don't even let it enter their mind that they want to be anywhere but with us.
Great. That's great. We've been talking a lot about strategy so far, and we're a little bit past the halfway mark here. I want to shift a little bit to sort of tactics and approaches to overcoming execution and implementation challenges. So, Haas, I'm going to bring you back in. What are the challenges for payers as far as execution? And maybe what are some of the pitfalls that payers should be looking out for and trying to avoid?
Right. So, I mean, I think I'll answer that in the positive in terms of, you know, what you need to have, right? And the raw ingredients have already been laid out, you know, so far in this session, and I'll just try and pull it together. You know, at the end of the day, you have to have a provider-friendly solution in order to have a provider-centric approach to risk adjustment and quality at the place of care. That means you've got to be respectful of their time. You have to compensate them and their staff well for what they do. And, you know, as Colleen said, you've really got to make the investment in making sure that what you're showing them is timely, reliable, and trustworthy. We put a lot of effort into that, and I completely agree with that. You also, as Frank said, have to make sure on the back end that you review all their work so that they know that there's someone back there checking that's a professional to make sure that they haven't made any mistakes. That's very reassuring. That was one of the things we implemented back in 2016 because we recognized that providers were nervous about that liability. And once again, Colleen mentioned that as well. I also think, number two, it's really important that you recognize that you have to have what I call a payer agnostic solution. You know, Michelle mentioned this, right? You can't just trot out there and say, here's my payer form or here's my payer system, and then the next person comes along, right? At the end of the day, you have to go and operate in their world, whether it's, you know, within their EMR or it's some other platform that they're comfortable using. And I want to just share a statistic that we've measured carefully here, just to give you some insight. You know, the Vatica application is something that the providers and their staff log into separately from their EMR. And we've been kind of watching EMR standards and the marketplaces open up because we wanted to be in EMR. And there was a lot of health systems, you know, that had said, hey, that's really important to be in the EMR. And we now offer that capability, you know, with several different EMRs and are rapidly expanding that. But we actually look at when the providers do their work, the date and time and how long they work for, 7 days a week within our application. And we can see that some people like to do it as they're doing their encounters. Some people do it at lunch. Some people do it end of every day. Some people save all their work, you know, and do it like every third night. And some people do it Saturday mornings. And when we surveyed our physicians and said, hey, do you want to bring this work in EMR, right? Only 50% said they wanted that. The other 50% said they liked just logging in, having it all in one place, and just doing the work in batch. So I think it's very important to recognize something I said earlier, which is you really have to take the time not only to understand the provider organization that you're engaging, but the providers underneath that have to do the work and what their preferences are, and start out with a few physician champions or sponsors that ultimately are going to give you some feedback about what they think is going to work best for their colleagues. It's just so important. And you just can't walk in there and think you know what the right answer is, because you don't. you've really got to elicit that, through the conversation and be nimble. And, in the beginning, I would say we probably had 20 different workflows. No kidding. And that was because I just said to our head of clinical operations, whatever they want, do it. Figure out how to do it. Don't worry about standardization and scale. And that's a key point that I also want to make that I think is a mistake that I see health plans commonly make, which is, how do we do this at scale? Well, hold on a second. Let's just figure out how to get it on the tracks in your marketplace and make sure that providers, are willing to do this work. Once you do that, then you can distill those workflows down. And, now we have it down to probably 3 or 4 workflows, that have become fairly standardized as we've kind of managed from the edges back in. So I think that's also very important to recognize as you go out to market.
You give us.
I'm sorry, Eric, I just want to make one more really quick point that Greg was emphasizing about the member. I want to remind everybody that the Affordable Care Act put medical loss ratio limits in place. So a Medicare Advantage plan cannot have a loss ratio below 85%. That means when you do great risk adjustment as a health plan and you're driving the highest risk adjustment yield to get appropriate premium for your claims, you've got to put that money back into benefits for the member or payments to the provider. There's this misconception that this all is for the benefit of the health plan and the profitability of the health plan. The government has actually ensured that that's not the case, right? And so I want to make sure that it's not only about educating providers about, why they need to do this for appropriate and compliant risk adjustment. It's also because at the end of the day, it puts more money back into benefits and into provider compensation. That's it. Thanks.
I actually wanted to hear an example. If you could tell us a success story.
Yeah. So, one of, in the early days, we were primarily signing up, regional payers, a lot of Blues plans. And then, now we've obviously moved into, national payers and, broader geographic expansion, but the best case study I have is just one of the regional payers that we supported in the Northeast. And, they went all in, right from the beginning. They wanted to make a hard shift away from retrospective chart retrieval and home assessments. And they said, we're going in office. We're going to put money behind this. And it was really a great learning experience for me to see what happens when you just commit to that shot. And so, at the end of the day, over a 3-year period, we were able to ultimately generate, primary care driven PCP centric risk adjustment assessments for over 70% of their membership. And, we ultimately generated additional premium of 15% of the premium that they were receiving. That created products that had lower member premium and then 0 member premium. Then other payers that competed against them wanted to be part of that. And so now we have 80% of the Medicare Advantage lives in that marketplace in our program. And we have over 70% of all primary care physicians in that marketplace participating in our program. So I just want to make the point that once you get started and you start to get some momentum, it can really start to build when the payers recognize that they need to have a payer agnostic and therefore provider centric solution. And if you just chip away at these basics that I mentioned earlier, you can actually achieve great success. That same health plan also took 6 of the measures that they were having trouble with that were under 4 stars to over 4 stars within the first year. To Colleen's point, you never want to just go out and knock on the door for risk adjustment. You're doing quality of care work at the same time. So risk and quality ultimately, generated for over 70% of the membership over a 3-year period. It's absolutely achievable, at a market level. And people just need to recognize you just got to march through the steps, year after year and make it happen.
It's great. I love that story. Those are exceptional results. And I want to come back to something that I think has been an underlying theme around our entire discussion today. And that's been workflow and how to think about workflow as you think about any program that you apply apply your strategies and your tactics to. So I'm going to do that. But right before we do that, I want to stop for a quick final PSA. My team, me personally, works with all of our audience and sort of how we can continue to build our programming in ways that are especially meaningful. And a lot of the feedback we've been getting over the years is it would be great if we could bring everyone together for an event. And so we're actually hosting our first live event this summer, August 24th and 25th in Boston. And we would love for you guys, if you're at a payer or provider organization, to come join us. It's a payer provider only event. And if you want to support the event through sponsorship, if you sell into those markets, by all means, reach out to me or my head of business development, Tony Flynn, and we'll talk to you. There's ways to do that in a cost-effective way. But the feedback we received is we're sick of big conferences with PowerPoint presentations, so there's going to be no PowerPoint presentations. And we want a way to better facilitate networking and learning from each other. So this is going to be a roundtable only event. We're going to have themes that flow out the day and a half around whole person care, consumer centricity, provider partnerships. I will moderate a panel like this one to lead off each theme, and then we're going to break out the entire audience of payers and providers into their own private breakout roundtable discussions with a professional facilitator. And that's how this day and a half is going to work on the shores of the Boston Harbor. So I hope you could join us if you want more information on this and you're a payer provider organization, or if you simply want to consider supporting it through sponsorship. We'll put up a poll there and we'll follow up with you as appropriate. So I want to bring in back Michelle Illich. She's the Vice President, Network Solutions and Value-Based Programming at Priority Health. I talked about workflow. So Michelle, how important is it to understand workflows when launching a new payer provider platform? Why is workflow so critical to being successful around any implementation? And specifically, how did you guys assess or apply workflow intelligence to the creation of your program?
Mm-hmm. As many of us have talked about, providers do not think in line of business, but insurance companies do. And so the hallmark that our efforts at stake are, and again, as I said before, EPP, Epic Payer Platform, is just the catalyst. We're taking an all line of business approach. So a provider doesn't want to hear as part of a workflow, do this for your ACA retro, do this for your MA retro, 140,000 charts here, 55,000 charts here. You're dead on arrival. And so what we do to inspire this conversation outside of just this coding to the highest level of specificity is really thinking about pre-visit planning. So what elements can we provide to a provider group, whether we liberate the data through EPP or through raw claims feeds that we send, to make sure we're the leading catalyst for that pre-visit planning? A lot of provider groups talk to us about empanelment. They want to go after the patients that they have an actual encounter. They've laid hands on them and siphon their workflows off from that. What we're trying to do is telling them, yes, go after those patients because they're in your EMR. And then let's have a reconciliation process together to make sure that that patient you're going after is actually the patient that is showing up on our level 1, 2, 3, 4, and 5 in terms of a high-risk patient designed for care management intervention. That is how harnessing the data, taking away the noise that carriers often do about, I want this for ACA, I want this for MA, taking that away, giving really rich raw claims feeds, giving the technology through Epic Payer Platform or other tools we're using with disease registries, and make it one experience so workflow is designed in that manner. I'll give you one other quick example. We have found out the hard way that oftentimes you're putting together a list of a patient that is either deceased, that is no longer living in the county that you're in, a doctor is retired, and you can never recover from that moment with a provider. You'll never get that legitimacy as a carrier if you're giving a list of patients that aren't truly their patients or there's a known reason why. And so we try to lead with that to say, we want to scrub our data in such a way so that your workflow is truly reflective of the patients who need your care the most. So then risk adjustment just comes behind that actual clinical experience of an annual wellness visit, an IPPE, or just a wellness check. And then the technology comes behind. So in sum, when I talk about workflow, I'm talking about workflow that's patient-centric, that's making sure mom, dad, sisters on the list because of their chronic diabetes with neuropathy. And they're not on the list because the payer got the data wrong or picked the wrong patient or forgot that the doctor deceased or retired. It's really because it's about that patient empanelment for all lines of business. And then the technology comes behind to perfect it.
Well, that sounds like a whole episode right there on workflows. That was great. I want to now shift a little bit. It's a nice transition to educating providers here and really focusing on provider engagement. So I want to bring back in Colleen. Colleen, how are you guys focusing on better education and better engagement with providers in New York's Capital District?
Yeah, so Eric, we don't train our providers on risk adjustment because if we did, it would require educating the providers on risk adjustment, which changes, as we know, we're seeing historic changes. And it would require pivots on the provider's behalf when the models change. And it's not reasonable to expect a busy clinician who's focused on patient care to change their documentation depending on who the patient is in front of them. So that's why we're going to be focusing on how to document for a chronic condition, not for risk adjustment. The great care that our providers give to the patient doesn't change depending on if that patient has Medicare, commercial, or Medicaid, and their documentation and their coding shouldn't either.
Great. When we're thinking about anything to do with asking providers to do more or pay attention a little bit more, we have to be very sensitive to sort of where we sit as a healthcare industry, and providers were sort of beginning to have provider turnover and burnout at record levels prior to the pandemic, and now it's reaching complete epic levels. I'm going to bring back Frank Shipp at Johns Hopkins Medicine. Frank, sorry. How are you guys thinking about provider burnout, and as you approach, risk adjustment strategies with health plans and how to get your providers sort of better suited, but understanding burnout as well? How are you managing that?
Well, it certainly is a challenge. I would say this, it really starts with the messaging. We could talk about the incentives, and they're important, but it really starts with the messaging, as Michelle gave some examples of that. I mean, our initial message has always been, we want to our providers, is that we want to help make sure you get the credit you deserve for the acuity level of the patients that you're caring for. And in this world of healthcare today, to be a good doctor or a good care provider, often is measured by discrete or non-structured data that's entered into a field and transmitted into a portal. And if it doesn't get there, so I guess the point we want to make is we do the heavy lifting, but we want to make sure you're getting the credit for that. Now, and I think that generally resonates amongst all the other responsibilities that providers have. But I want to say something about the incentives, because at the end of the day, they are critical to help understanding why they're being asked to do the work.
Frank, when you said earlier, and now you're about to talk to incentives, are we talking about connecting the dots here?
That's right. That's right. Because as a provider network that's involved in value-based care programs, MA, or even other value-based care programs where risk adjustment is paramount, it often takes time for them to see, or for the provider network to see or quantify the financial rewards in order to build some of those metrics into the compensation model. It doesn't happen overnight. A lot of the models include non-RVU based incentives such as productivity, closing charts. But to really build in some of these incentives into the compensation model, to hardwire that incentive, you really need to see the results. And that takes time. So I would say also to the payers out there, the payers really need to also consider enhancing the incentives that they provide in these programs to the providers. So I think it works two ways there. But aside from the incentives, the messaging is really critical. The engagement is really critical. And when you have both, now, then it's very powerful.
Michelle, what about a priority? Like, how are you thinking about the same problem?
Well, I think the first part of it is admitting that there is a problem. I think we're trying to get out of this era where providers are feeling just beat up by insurance companies every day. It's a new surprise, whether it's, changing a policy or adding additional claim elements. And I think the bigger piece that we try to talk about in our state, we're very proud of the fact that Priority Health has a very large proportion of patients on high deductible health plans. You notice I use the word patient, not member. I never let myself or my team use that word member. We're patients. We're having a shared experience here. There shouldn't be members. They should be patients. And so when we talk about these things, we talk about the patient who's footing the bill of that high deductible health plan. Wouldn't it be nice if we all work together to really coordinate and think about solving that problem, because they're really footing the bill in terms of the out-of-pocket expense. I think the other part of this is just admitting that burnout is a real reality. We try to use the word quadruple aim quite a bit. It's not just about achieving care to achieve the triple aim, lower cost, improve quality, improve patient experience. It's bringing the joy of medicine back. We, as a crisis, right now, to really inspire people to want to be in primary care. And so if we're not leading that charge as a provider-owned health plan, who else will? And so I think the biggest piece in reflection is, as a payer, don't pretend that it doesn't exist. Number one, say it. Two, admit when you're sending out information or data elements or new policies that are causing friction, and ask them to participate in helping you fix that. And then I think the third part about it is making sure that that quadruple portion is at the forefront of everything that you're doing. And it's not members, it's patients.
Well said. I one follow-up for you from your previous answer that I'm just going to take from the audience right now. You mentioned mistakes in attribution. How are you getting those rectified? Can you provide a process that you've used to do that?
So I like to remind folks, and if anyone on this line is familiar with the CCLF files for Medicare, I think they're on version 53. So the first thing I say is that attribution is a journey, and I would strive to not be an organization that has 53 versions of my data files to improve attribution, maybe just 15 or 16. So the first thing is attribution is iterative. Claims data is inherently latent. And so what we are trying to think through is, what can we do to make sure, one, we're very transparent with our attribution. Was the member attributed you because of step one, meaning the member declared that they wanted to be assigned to you, Eric? Or was the member assigned, or did a Medicaid plan auto-assign? So the first is at transparency. What step in the process? Step two is really earmarking what proportion of those patients have that highest volume of services, and being clear with that. And then we're striving to get to a state, we're not there yet, where we can actually be very clear about what programs these patients have been enrolled in because they're attributed to the panel, so that we really can divide and conquer, especially those who are in risk contracts, to go after those patients. Attribution's a journey. That's why I always start off with is I strive not to have a 53 version manual, but we do have a manual to just really share in that tension. A delivery system wants to go with empanelment. It is the gold standard. Insurance companies have a massive administrative claims data that's dirty and ugly and requires logic. We've got to figure out that versioning together.
Well said. As we get ready to close here, folks, 2 upcoming events. If you want us to pre-register you for free, our next live episode is going to be on reducing total cost of care and talking about whole person models, innovative whole person models. That's going to be on May 11th. Next week, we're having a private roundtable that for payers and providers that is going to be specifically on building sustainable social care programs. So for the May 11th webinar, if you want us to register you so you don't have to go through it again, just click yes. And then Sherry is going to put up a similar poll if you want to join our private roundtable, and you have to be a payer provider to participate in that. To our esteemed group of panelists, thank you so much for all the time and the effort you put into this. This was a great conversation, as I expected it to be. I actually dubbed it on LinkedIn as going to be the best RA episode of our illustrious 10 years here. So I think you met its billing. So thank you for all that. My message to everyone who's listening, use the strategy of looking for bright spots and things working well among all of the chaos, because these are the strategies and tactics that often generate progress and change your organization's entire path and provide a solution to often your toughest challenges, like optimizing risk adjustment and staying compliant. We hope you use the bright spots shared today to inspire your thinking and enhance your organization's approach to improving healthcare for everyone. Thank you all for attending. This is your Bright Spots in Healthcare podcast.